Good afternoon and hello. This is a lecture on disorders of the blood, and hematology is the word that we would use, and alterations means disorders of. I'd like to start with a little bit of a video on sickle cell anemia. It's been a disease that is characterized for a long time. It's a genetic disorder affecting mainly the African American populations. And it results in red blood cells that are abnormally made. They're a little bit sickled shaped, dysfunctional. They're not good at doing their job, which is to deliver oxygen. But there's a chance that it causes a lot of debilitating pain. A person lives with a lot of flare-ups and pain, and it's not good. But there's a little bit of an idea that there might have been a cure created. So let's start with that.
A patient on Long Island is making medical history. Doctors say he is the first in New York to be cured of sickle cell anemia. As Jennifer McLogan reports, the patient is pain-free for the first time in his life.
Sickle cell was like a blockade for me, but now it's just like a wall that I just jumped over.
For 21 years, Sebastian Bozil suffered chronic pain from debilitating sickle cell anemia. He's now making medical history in New York State.
The cliche, the future is here, is actually true in this case.
We feel blessed to be able to be the first ones to be able to offer this.
Groundbreaking Lyfgenia treatment used Sebastian's own bone marrow in IV transfusions to create normal red blood cells.
When we could use Sebastian's own stem cells to do this therapy, we were delighted.
Sickle cell disease was described in modern medicine in 1910, and here we are over 100 years later, and this is the first cure you're seeing.
To the Med4 team, the hematology team, the transplant team, you guys have really changed my life.
In the United States, sickle cell anemia most commonly affects people of African, Mediterranean, and Middle Eastern descent. Cohen Children's Hospital hopes to target those communities with this life-altering therapy.
Sebastian been coming to this hospital since he was 2 months old. There is not enough word to show you how grateful I am.
Sebastian will soon be able to travel, work out, and focus on his education. He hopes to work in the medical world.
Amazing, and I can't wait to get back to my day-to-day life because now I feel unstoppable.
From New Hyde Park, Long Island, Jennifer McLogan, CBS News, New York.
That is truly amazing, and we wish you all the best, Sebastian. By the way, today, civil rights attorney Benjamin Crump announced a $100,000 donation to Northwell to further the health system's efforts to treat sickle cell disease.
So yeah, that's meant to
A
be
patient on
sorry,
Long
sort of meant to be get you excited about blood disorders. I know it seems odd, but yeah, in my lifetime, I didn't think I'd see that. But that just speaks to volumes to the importance and necessity of research, and in particular, funding that supports research. And right now in time, in 2025, that's being threatened. And I am upset about that in more ways than one. But anyway, let's get back to the topic at hand, which is blood disorders. And I'd like to discuss some general blood cell processes and pathologies, but these are mostly terms. You probably know, if you look here on the right, if you remember from A&P, you have three main types of blood cells. You have white ones, you have red ones, and you have platelets. White ones, we think of infection fighting. Red ones, we think of delivering oxygen. And then platelets, we think of blood clotting. But there are some words that are included in all of this, and I'd like to try to break through some of that. So if you see the word cytosis, it means something of the cell, and it often means too many of these cells, but it doesn't always mean that. But anyway, pinia is usually a lessened state, like there's less of them. So if you heard the word pinia, sorry, it would mean less. Poesis means the making of. And it actually comes from the word to make or to bring. There's a lot of Greek or Latin in all this, and to make or bring poetry. And I just think that's a really cool thing. Poly usually means more. In the case of polycythemia, too many cells. And philia is also one that often refers to like affinities or migrations of cells, meaning a little bit more of. And so anyway, there's some terms to get your head around, but mostly it's cytosis and pinia that we're working at. But if we did look at the word erythropoiesis on the left, that would mean it would be a term that's related to how red blood cells are made. Leukocytosis refers to a condition where there's a problem with white blood cells. Leuko is usually related to white blood cells. Cytosis is of the cell, and in a lot of cases, like leukocytosis is too many. Leukopenia would be a condition where there's too few white blood cells, and thrombocytosis means there's a problem with the blood clotting platelet system. Thrombo refers to platelets. So there's a lot of terms, and again, I've always said, in my opinion, nurses, anybody in the medical profession should take med term at the very early end, beginning of their college career, to kind of get some of these terms laid down foundationally, because then it helps you later when you have to kind of quote memorize things. Anyway, I digress. So let's look at some of these. Erythropoiesis, I'm going to do this relatively quickly, but erythropoiesis and erythropoietin, that's a hormone that's produced in the kidney, but all of this is about making and producing red blood cells in the bone marrow. And there's other factors, but if we're other regulatory factors, for the most things, erythropoietin is the main hormone, and it's coming from the kidneys. The kidneys really bring a lot to the table, but even in the situation where they're helping with red blood cell production. If we have too many, it's erythrocytosis, and if we have too few, we usually refer to those in the terms of anemias. Leukocytosis is when the white blood cells are elevated, and that can be normal, or that could, it just could be a temporary thing, or could indicate something like a leukemia or a bone marrow disorders. Now, leukemias are a little tricky because they're a little bit of a condition of too many of one white blood cells is crowding out another white blood cell. So just keep that in mind when we talk. But anyway, there's some other terms that you could relate to all of blood cell disorders, but we're going to kind of go and hit the main ones at this point. So looking at how do we get a low blood cell count, leukopenia, there's basically three ways that can occur, and then there's subways. You can have reduced production in the bone marrow, or you can have increased destruction of them, hemolytic destructions, or some other forms. And then you could have causative agents like radiation, or there could be congenital in the other group. So if you look at leukopenia, which is low blood, white blood cells, you can look at things that are problematic in the bone marrow. The bone marrow is what's producing these, and we'll look at that later. And so infections could also be a cause, and medications and nutritional deficiencies. All of these could lead to conditions where you have low white blood cells from a production standpoint. From a destruction standpoint, you're going to be looking at your big old spleen. It's a neat little organ that's involved in filtering blood, and it also, if it gets overused, it can get enlarged, and it contains all white blood cells, and it can get enlarged and be defective and cause the increased destruction. And also, your immune system, when your body attacks itself, in the case of like lupus or rheumatoid arthritis, your own self could destroy your white blood cells. And finally, the other causes that we just briefly talked about, radiation. When you have exposure to radiation through cancer drugs or some other exposure, that could reduce white blood cell production, and there's congenital mutations that can also interfere with the development and maturation of some of those white blood cells. In the case of this last one, neutrophils are a type of white blood cell. All right, so what are some of the symptoms of having leukopenia, which is low white blood cells? Fever, chills, sore throat, mouth sores, fatigue, and rash. In another, either in class or in another lecture, we'll look at how do those symptoms relate to the pathophysiology. We'll get into that, but for now, those are the symptoms, and complications would be an increased risk of infection and sepsis. And so if you understand what a white blood cell does, you can understand if there's a problem with it, you could be what you could be at risk at. And later we'll go into more of the pathophysiology with some of the symptoms. So we'll hopefully connect to that. Like obviously if you have low white blood cells, you're not fighting an infection, you're going to get fevers, chills, sore throats, mouth sores, because you can't fight viruses and bacteria that are always there. All right, let's look at thrombocytosis. Thrombo again means something related to platelet and platelet issues. You can have too many, and there's a lot of ways you can get that with anemia and increased, it could be a response to like infections and surgery. But it's thrombocythemia is an excess or too many of those. And even alcohol withdrawal. I didn't know about that until I was researching this and reminding myself of this. But the symptoms would be easy bruising or bleeding and blood clot, stroke, numbness, headaches, and dizziness. So keep those in mind. All right, some of the disorders that we'll talk about, and in general terms, we're going to look at anemias, where you have fewer typically red blood cells, or what we refer to with anemias, or you can have less hemoglobin or less, whatever it is, it's the reduced ability to carry oxygen and to release oxygen to the tissues. Bleeding disorders, that's an impairment with, you could have too much or too little bleeding, and that relates to your platelets, thrombocytes. Blood clotting disorders are along that same line with bleeding or clotting disorders are related to platelets. Blood cancers are also those that are related to too many of cells, but again, some of those cause crowding in the bone marrow or in the systems of the blood, and so you could have less delivery of the ones that are getting overcrowded. And finally, there's other disorders that we are sometimes classified as anemias, but they're just a little bit different. They're related to autoimmune or genetics, and so we sort of put them in a different category, the other. So for the anemias, you have two, whoops, there's a typo there. It should be TOO, few white blood cells, aplastic, folic acid, iron, pernicious, hemolytic, or sickle cells. All of those are ways, or different reasons why the red blood cells, do not function. Aplastic anemia could actually be, it's usually a bone marrow disorder that affects more than just red blood cells. It can affect all the blood cells, including platelets. But iron deficiency, if you don't have enough iron, if you don't have enough folic acid, hemolytic, thalassemia, sickle cell, there's different reasons why red blood cells don't work. We'll go into detail later. But we can also have bleeding and clotting disorders, DIC. That's one that's really bizarre because it kind of can have both conditions where you bleed or you clotting and bleeding are affected because of sort of an overreaction in a way. And like I said, there's blood cancers. You got your main ones, which are leukemia and lymphomas. And so, yeah, there's even one called polycythemia vera, where you have too many red blood cells, and that's actually a characteristic of it's referred to as a malignant condition, but not it's with red blood cells, and so it's kind of unique that way because usually it's the white blood cells, the leukocytes and the lymphocytes that are affected by cancer disorders. But there is one it's not always used the word cancer, but malignant is used. All right, moving on. So anemias, we've already been over these. That's the generic term, again related to blood cells. When you have aplastic anemia, there's just not enough. Your bone marrow fails to produce enough of any of them, red blood cells, white blood cells, and that could be because of infections, medications, or toxic exposure. If you have a deficiency in B12, it's called folate deficiency anemia, and that's when you don't have enough folate. A B vitamin, that's what folate is. It's used in the production of red blood cells, so your red blood cell production is affected, and then as a result, they're also destroyed faster because of similar conditions like sickle cell or autoimmune disorders. Those are all kind of related can affect B12 deficiency. Iron deficiency is the most common, where people do not have enough iron. B12 deficiency, it's another B, but we just call that one pernicious anemia. It's very similar to, I'm sorry if I said the first one was B12, but folate is different it's a different B vitamin. My bad if I said that wrong. But yeah, so some of these B12s and the other B vitamins and iron are all used in the production of red blood cells. Hemolytic anemia is different. It's when your body can't absorb one of those and it's leading to decline. And it's also the blood cells get destroyed. It's a general term. This was a little slightly misleading because hemolytic can be anytime red blood cells are destroyed as well. Sickle cell's genetic. There's abnormally shaped red blood cells, and that leads to premature destruction and dysfunction. It can't really carry oxygen why you would like it to. So that's why there's some breathing difficulties and pain. Both of those things. The spleen can't handle these misshapen sickled cell red blood cells. Ironically, it's a good thing to have if you were genetically heterozygous for sickle cell, you would get a few symptoms, but as a bonus, you get a little bit of resistance to malaria, which is an interesting thing. That's another topic. And thalassemia is another group of inherited blood disorders where there's it's hemolytic as well. It's red blood cell production is also reduced, and the body produces abnormal hemoglobin. It's related to the structure of the hemoglobin module. I'm sorry, model molecule. Sorry, and it's also related to mutations. All right, here's a quick summary of symptoms and diagnostic features. You could make sense of some of these if you're gonna look for somebody. The symptoms for anemia are very similar, but there's some subtle differences. But some of the main anemias you're going to see, fatigue, for example. But there's some diagnostic features with iron and the different ways the blood cells look, both in shape and color. And so, without getting boggled down in it, just keep that in mind. But obviously, low iron would be a good indication of anemia based on iron deficiency. Same with B12 and folate. So the subtleties come with hemolytic and sickle cell and aplastic and thalassemia. There's some differences there with reticulocytes, which are immature red blood cells, but don't get overthinking any of this slide. It's just there for your information. But as I mentioned, we can classify anemias based on, size and shape of cells. And so, in the amount and volume. So are, even the color. So there's cell this chart doesn't show you, but even the color of the red blood cells can give you a diagnostic clue on which type of an anemia it is. So you don't have to memorize microcytic, normocytic, and macrocytic and which ones are which ones, but you should know that there are more diagnostic references out there that relate to size. I would know this on a general scale, size and number and color, if that makes sense. Morphology, I guess, is what I would say. There's normal and macro and micro and the counts, and then also color. All right, so some bleeding disorders. So there is a video on DIC, but we'll take a look at that. And there's so that's an odd clotting disorder and bleeding disorder. It's something that happens. It's not. It results from other traumas or other illnesses. It's not necessarily a disease. Hemophilia is. It's what we call a bleeding disorder. There are clotting factors that are used to form clots in the clotting cascade to stop bleeding that are missing. And so this person can't form good clots and they bleed. DIC is different, and I'll get to that in a minute. But while we're on hemophilia, you should notice that it is genetically a sex-linked recessive condition. So if you see, I'll move my face here for a minute. If we look at our good friend, the Punnett square, these are the sperm, and these are the egg up here. These are the possible combinations from this mommy and this puppy. And you can see most people, if you're a carrier, this person is not going to express hemophilia. You would need 2 of these. So a girl is very uncommon because it's not usually on the X chromosome, basically. But when it is, I'm sorry, it's not usually, there's no Y. And so it's hard to get two H's because some of that information is missing from the male. But what you see here is the Y doesn't really have this extra space. So it only takes one recessive gene in a sex link, and it's going to be inherited from the mom's side because it's right here. Sorry, where there's a recessive gene, and again, this mom would need two of those little ones, little H's, two recessive genes to get the condition. And so there's just a lot of dominant ones out there. But if mom is a carrier hiding that and meets up with the sperm that's the Y carrying sperm, there's nothing on this arm to counteract that. And it doesn't have a gene for it, basically. So it's just taking one recessive. Anyway, I digress. So let's hit this a little bit here.
Disseminated intravascular coagulation, DIC, is disorder characterized by diffuse small vessel thromboses and hemorrhage. It means small-sized blood vessels are occluded throughout the body, producing widespread ischemic damage. And same time it causes deficiency of platelets and clotting factors and result is bleeding in the body or outside body. Bleeding occurs from the GI tract, nose, epistaxis, and every puncture sites, may result in a normocytic anemia. Blood in the urine, blood in the stool. Symptoms may include shortness of breath, chest pain, leg pain, problems moving parts of the body. Some cognitive problems may occur. In disseminated intravascular coagulation, the underlying cause usually leads to symptoms and signs, and DIC is discovered on laboratory testing. The onset of DIC can be sudden, insidious, and chronic. Relatively common causes: massive trauma, car accident, extensive surgery, hypovolemic or cardiogenic shock, cancer, and complications of pregnancy. Infection, bacterial, gram-negative or gram-positive, viral, fungal, or protozoan. Less common causes include snake bites, frostbite, and burns. Transfusion reaction, ABO incompatibility. Malignancies, acute promyelocytic leukemia, adenocarcinomas pancreas, prostate, lung, breast. Obstetric problems, amniotic fluid embolism, abruptio placentae, toxemia of pregnancy, dead retained fetus. Gram-negative septicemia, for example, meningococemia caused by Neisseria meningitidis, with release of neurotoxins, is the most common cause of DIC, greater than 50% of cases. Diagnosis: low platelets, low fibrinogen, high INR, prothrombin time, or high D-dimer, fibrin degradation product. Treatment: treating underlying cause is crucial. In addition, giving platelets, cryoprecipitate, or fresh frozen plasma. About 1% of people admitted to hospital are affected by disseminated intravascular coagulation. In those with sepsis, rates are between 20% and 50%. Prognosis varies depending on the underlying disorder. Regardless of cause, between 20% and 50% of patients will die. DIC with sepsis infection has a significantly higher rate of death than DIC associated with trauma.
All right, so let's get out of this somehow.
Disseminated intravascular coagulation, DIC.
All right, sorry, back to my chart. All right, so sorry for that. It's always a little awkward. Thanks for hanging with me. Bleeding, clotting, DIC, whatever you say, disseminated. It's a complex condition in the sense that what you have is some underlying disorder. If you follow this little chart here on the right, and you get this systemic activation of coagulation. It's similar to in sepsis when you get this intense response of the immune system to fight that infection and it overdoes it. In this case, it's getting out of control, and there's this interplay between how you dissolve a clot and how you make a clot. And so that's what can lead to you've got this interplay. So you get this a little bit of clotting and then this excessive triggering of the clot dissolving, and that's where the bleeding comes. And so all of this, it's basically you get this overconsumption of clotting factors, which then lead to the bleeding. And so really weird one, but it's usually one that's associated with, like the video went into great detail about, I think, trauma, but there's a lot of ways that when things start to get out of control with the regulation of the clotting system. All right. Hemophilia, like I talked about earlier, it's actually in the current textbook that we're in on page 116 and 117. It's not within the hematology section, but it's sex linked, and there's a couple different clotting factors, hemophilia A or hemophilia B. It's involved with the F9 gene, but you don't need to worry about that on the X chromosome. You probably need to know that it's sex-linked on that. So a quick look at blood cancers transitioning out of anemias and into blood cancers. You got your leukemia and you got your lymphoma. And if you take a look at this chart, this is a very basic concept of how stem cells make different blood cells, and they're found in the bone marrow, okay? And it's not red versus white in this case. It's myeloid versus lymphoid, and those are different. The blood cancers will result from different problems from these cell lines. And so your red blood cells and platelets and white blood cells come from myeloid stem cells. Your lymphocytes, B lymph, T lymphs, and natural killer cells, these aren't really lymphocytes, but they're part of they kind of are because they're from the lymphoid stem cell tissue. It should be easy to remember this because all you got to do is throw the NKT cells in there, natural killer cells, with the lymphoblast or the lymphoid stem cell tissue. B and T, these are considered white blood cells, but these are not. But it's interesting how the bone marrow makes them. And so that's a good chart to kind of keep a framework of the different types of blood cells and where they're made, because that can lead to a better understanding of some of the conditions. All right. Again, looking at myeloid versus lymphocytic, all right, you've got the leukemias, which would fall into, you could see the L's here, or the M's give you a clue whether or not a leukemia is resulting from this line or this line. I hope that makes sense. And what I would like to say also is usually the acute conditions are a little bit more harder to remiss or get into remission, I should say. So there are subtle differences between ALL and AML. But again, of what you should notice here is the A is for acute, the L is for lymphocyte, and the other L is for leukemia. And so it's either acute or myeloid, or acute or from the lymphocytic side, or chronic lymphocytic and chronic myeloid. That, excuse me, is a big concept that I'd like you to kind of get your head around. The details can come later with how, the different systems and diagnostic features. But one thing that we'll probably look at later in class is how chronic myeloid lymphoma and are chronic lymphocytic, some of those are more onset later in life, and they're treatable. They are not curable, but treatable. But anyway, here's a little bit of a microscopic diagnostic look, just for fun, but you can see some of the differences between AML, CML, ALL, and CLL. Again, these are all different kinds of leukemias. All right. And so, looking at different symptoms, but the CLL, there's really not a lot of symptoms. You kind of accidentally find it when you do blood analysis for something else. All right, the other kind of blood cancer is lymphoma. They start in the lymphatic system, and there's two main types, Hodgkin's and non-Hodgkin's. And the differences are, kind of Hodgkin's lymphoma is a little easier to manage. But anyway, you can see some of these, there's some rash involved and some swollen lymph nodes. So looking at the biggest diagnostic difference between Hodgkin's and non-Hodgkin's lymphoma is highly illustrated here in the slide. It's the presence of what's called Reed-Sternberg cells, and it's also a less common one. So in Hodgkin's, you would see these cells that they're kind of, they're derived from B lymphocytes, but they look granular and they look like an owl. And that's what's a big characteristic. But there's also some subtle things in non-Hodgkin's lymphoma that originates from sites that are outside of the lymph nodes and then spread to lymph nodes. And it's a very common type, a little more easy to treat. Not as easy to treat. Hodgkin's lymphoma has the Reed-Sternberg cells and arises in a single node or a chain of nodes. But basically, you're going to see similar symptoms with swollen lymph nodes, fatigue, fever, night sweats, and weight loss, and itchy skin. That's a characteristic. You can see, again, the owl-looking cells, and again, the Reed-Steinberg cells, again, with the Hodgkin's lymphoma, and I'm trying to connect that with you with an owl. So that's a very key diagnostic difference between the two of them. All right, the last thing we're going to look at is polycythemia vera. It's basically a malignant form of excessive red blood cells. There's just more of them. It leads to very thick and viscous blood, could become part of a cancer in the bone marrow. Usually it onsets later in life, around 60, and more likely it's caused by mutations. Symptoms are similar, but you'll see the legs or the arms look red. That's one of the big things. But the symptoms are similar: fatigue, weakness, but that red skin and mainly is one of the things that's pretty diagnostic with this. Shortness of breath. The blood is just thick. It can't deliver oxygen like it needs to. Headaches, nosebleeds. But you see overlap in all these symptoms when you have blood disorders. We'll sort some of that out later. All right, some complications include blood clots, which could make it dangerous for, obviously, if you have, it's very thick and hard to move, bleeding, gout, kidney stones, and scarring of bone marrow and leukemias. All right, that's it. We're going to be done with this lecture and hope you enjoy.